Welcome everyone to today's program, Jacking Up the Bar. Can targeted inhibition of JAK-STAT signaling improve patient outcomes? We're broadcasting from UEGW. My name is Maria Abreu. I'm a professor of medicine. I'm director of the Crohn's and Colitis Center at the University of Miami. Professor Silvio Danese from Humanitas in Milan joined me earlier in the studio to discuss the pathophysiology of ulcerative colitis and how it has informed the treatment changes that have occurred over the last 20 years and continues to evolve today. I'll then discuss the evolution of clinical trial endpoints and the recently updated IOIBD STRIDE-2 recommendations, which I hope you will agree with me, have really raised the bar on the outcomes we can achieve in patients with ulcerative colitis. And then finally, we'll be joined by Dr. Tim Rain, direct from the clinic at Addenbrooke's Hospital in Cambridge. He'll be presenting a case of ulcerative colitis. He's going to focus on treat to target and how we can implement that in real life. And he will be discussing with us the latest clinical trial updates in JAK inhibitors. So I'll begin by turning this over to Dr. Silvio Danese. Silvio, thanks again for joining me in the studio. We've come a long way in treating patients with ulcerative colitis. What do you think have been the biggest changes in the last few decades?
Thank you, Maria, for this very nice question. Then let's make together a walk through the key highlights and milestone in ulcerative colitis treatment evolution. And actually, if you recall, it was in 1859 that Miss Bank was the first patient in which the term ulcerative colitis was introduced for the first time. And then it took around 6 years to use surgery as a treatment option. And after only 20 years, 25 years, there was the first introduction of the anti-inflammatory drug sulfasalazine and 5-SA. And then, after 10 years, there was the first introduction of steroids as a rescue treatment for patients with ulcerative colitis. And after 10 years, another milestone occurred. The first introduction of the first immune suppressant, azathioprine. It was clear that this is an immune-mediated disease and requires immune-mediated drugs. Well, it's also very important to highlight that we have done a lot of steps forwards the treatment of ulcerative colitis. Only 2 decades ago, it was described that treatment was stepped up or escalated simply according to the severity at presentation, but also the failure for each prior step. And I think this is something that we have recapitulated and reshaped in the modern management of our patients with ulcerative colitis. Well, let's look now at really the highlights, the evolution of the UC treatment landscape. And of course, anti-TNF have been the major step forward the treatment of our patients, and with all the new mechanism of action. You can clearly see that in all these last 20 years, we have really moved away from conventional treatment, and with the introduction of the first monoclonal antibody, and then after anti-TNF, with all the recognition of the new targets, we have really evolved in the treatment for our patients. It's also important to remember that each step has taken some time, and now we are getting for the first time small molecules. In 2018, the first JAK inhibitors have been introduced, the first generation. But beside this success, we have had also a lot of failures. You see a lot of mechanism of action that have not really moved forward and have not been successful. So I would say that success and also failures have driven the treatment for our patients with ulcerative colitis. And understanding the pathophysiology of the mechanism of intestinal inflammation at the base of the intestinal damage that occur in our patients has really helped to identify more and more targeted therapies and advanced treatment for all our patients. It's not only a matter of the treatment that we use for our patients, but it's also a matter of the endpoints that have really evolved. And also, when we look historically on how from the 2005, in which we have had a definition of remission that was a little bit old-fashioned, moving towards the very latest definition in 2021, in which we have new aspects. For instance, just think about mucosal healing, how it's evolved. It's not only endoscopy, but is histologic healing combined, and also what we define as endoscopic remission. Very tough. At the beginning, in the middle of with the first anti-TNF, we didn't have a Mayo endoscopic subscore of 0, but now we are become more and more ambitious for our patients, and we want to have a Mayo endoscopic subscore of 0. And then after that, we have introduced the concept of histologic remission, and we really do not want to have histological inflammation for our patients. So I think that we have really evolved, not only for drugs, but also for endpoints and for our therapeutic overall ambition.
Silvio, despite these advances, what challenges remain for ulcerative colitis management?
I think that we have a lot of challenges, but before answering to this very difficult question, I always like to recap that ulcerative colitis is a very complex disease and also somehow is unpredictable. When you think about disease outcomes, it's very complex for all patients with not only the symptoms, but also for the morbidity that the disease has. And is not only for the disease outcome from a doctor perspective, but is also related to the patient-reported outcomes, to all the deep impact that on disability, on the impact on productivity of our patients. Most of our patients, as we know, are young. They cannot go to school. They will have impairment in their working capabilities. They always complain about fatigue and so on. I think that all these leads really to a very high burden of disease. And when we think about this, it's also very important to highlight that we have a huge room for improvement in the therapeutic management of ulcerative colitis. The first major challenge is the white space problem. That means that we have a very high white space in terms of efficacy bars that we want to achieve for our patients, and still we need to fill these gaps. What I define always, the therapeutic gaps, in order to achieve to 100% control of disease. Well, understanding the pathophysiology is very important, because at this moment we have always tackled one mediator, one cytokine, one pro-inflammatory mediator at a time, but probably the future is going to be inhibiting multiple pathways simultaneously. This is going to be key for driving our therapeutic success and to fill the white space.
Finally, Silvio, what potential role could new therapies play to address some of these treatment gaps?
Well, Maria, I really think that the new therapies play a key role in addressing some of the gaps that I just mentioned. Let's look at the latest advanced treatment with the JAK family. This is including 4 non-receptor protein tyrosine kinases. As you know, there are 3 JAKs, JAK1, JAK2, and JAK3, and then TYK. And while JAKs are always intracellularly located, they are very relevant because they transmit, working in pair, cytokines or growth factor signals, and are involved in a very broad range of cellular processes, particularly immune cell function and hematopoiesis. And while all the JAKs are ubiquitously expressed, and JAK3 is mainly expressed by hematopoietic cells, it's very important to understand that JAK1 selective inhibition may drive a major role in controlling inflammation. Well, I would say that JAK1 acts as a major hub for a broad range of key pro-inflammatory cytokines. And upadacitinib inhibits JAK1 by binding to the ATP binding sites of the enzymes. However, as you know, these sites are highly conserved in amino acid sequence across the different JAK family members. Now, when you look at this cartoon, you can clearly understand how upadacitinib has been engineered at a molecular level to optimize the interactions to confer both affinity and selectivity to JAK1. So this is a very unique molecule.
This structure uses a combination of electrostatics and conformation to provide an induced fit into key regions of the JAK1 active site, including a trifluoromethyl group, which is designed to stabilize a closed conformation of the glycine-rich loop, which builds selectivity, an ethyl group, which projects into a lipophilic pocket, increasing potency, a tricyclic core that provides conformational rigidity, stability, and hydrogen bond interactions, with a kinase hinge segment in order to increase potency.
So this leads to my conclusions of the key advances in ulcerative colitis management. The therapeutic landscape for ulcerative colitis has transformed from conventional therapies to biologics and small molecule inhibitors. And despite these advances, room for improvement remains for us to do more for our patients. Coupled with advance in therapy, treatment goals and trial endpoints have become more stringent, which will be important to consider in the context for interpreting the data from ongoing trials moving forward. So I give you back the word, Maria, for your session on this theme.
Silvio, again, thank you so much for joining me today in the studio. That was great. All right, so far we've heard from Silvio Danese about the pathophysiology of ulcerative colitis and some of the treatment strategies that we're using on these patients. Now it's my turn to talk to you about treat to target, the why, when, and how of treat to target. And so what is that concept of treat to target? And I'd like to sort of deconstruct it in two ways. One focusing on the aspects of treat to target as it relates to clinical trials, and the other on the aspects that have to do with clinical practice and day-to-day, how do we use treat to target? So first of all, with respect to endpoints in clinical trials, I want to give you a little history lesson and start you with the story of Truelove and Witz, who were really rock stars in their day. These were investigators in London who actually were pioneers of clinical trials, not just clinical trials of IBD, but clinical trials in general of placebo-controlled studies. They had to start at some point in time, and they really started in the 1950s. And these were the people responsible for using hydrocortisone in the treatment of ulcerative colitis, which was life-saving in its day. And in point of fact, actually, they weren't so far off from some of the things that we're doing today in terms of targets. And so these guys had a binary approach. People were either feeling better or they weren't feeling better and completely well. They either had an improvement in their endoscopy. At those days, they were doing rigid sigmoidoscopies, poor patients. And they also looked at histology, actually, in terms of their outcomes for clinical trials, and the rest is history, because obviously, even today, we continue to use corticosteroids in the management of patients with ulcerative colitis. From then, of course, there was an evolution in treatments, and so the mesalamine started becoming available. In a study that was using mesalamine enemas, Lloyd Sutherland and his colleagues developed, again, another scoring system that took into account patient symptoms. In the case of ulcerative colitis, really the patient symptoms we're asking them is frequency of bowel movements and how much blood they're seeing, but they also incorporated endoscopy into that score. And then eventually, at the Mayo, they led a clinical trial, again, of oral mesalamines, and they termed it the Mayo score, which in fact we use most of the time today, is the most frequently used in the clinical trials, and even in the kind of the day-to-day, how we talk about patients with ulcerative colitis in terms of their Mayo score, again, incorporating stool frequency, bleeding, and endoscopy, and this physician global assessment. But as you'll see over time, actually, in more recent clinical trials, we're sort of dropping that physician global assessment because we're endoscopists, and we really are kind of ruled by what the endoscopy shows and take that way too much into account in our physician global assessment. So I want to tell you a little bit about treat to target and really what does that mean? What does that mean for patients with ulcerative colitis? So the idea of treat to target is having a plan, having goals that you've set with the patient of what we want to achieve. In the case of the patient, that might be having a normal quality of life, not having to stop on their way to work to use a bathroom. In the case of you, the treating physician, it's whether or not the endoscopy was horrible and needs to improve and the inflammation needs to get better. And so you have to set realistic targets, but also have a plan of when you're going to check if those targets have been achieved. And if those targets haven't been achieved, be prepared to change or optimize therapy in that particular patient. So it's what I call the trust but verify approach to managing patients with inflammatory bowel disease. So STRIDE 2 is an attempt to really take these targets and put them into clinical practice and how you would practice clinical medicine. And STRIDE 2 was developed by the International Organization for IBD, which is a group of IBD physicians from all over the world with a lot of different perspectives and a lot of experience with how to manage inflammatory bowel disease. And the process was complicated, but I'll try to explain it to you in as few words as possible, which was really doing a very thorough literature search that involved librarians and fellows looking at all of the different studies that have been done in the last decade with respect to ulcerative colitis and the different endpoints in clinical trials, and then figuring out, having a voting process to figure out which one of these targets that were in clinical trials are really ones that we can achieve realistically in the clinic. And so we also have to take into account timing, right? Timing is everything in life. And so there are immediate targets that we want to achieve, there are intermediate targets, and of course we have long-term targets that we want to achieve. And again, these milestones are ones that you're trying to follow when you're conceptualizing this for the patients and when you're trying to organize when are you going to next check and next have a visit with that patient, or in modern times, a televisit with that patient. So these immediate outcomes is really more driven by the patient's symptoms. How are the patients feeling? Are they having a reduction in number of bowel movements and bleeding, which we know depending on the therapy that we've chosen for the patient, it could be a couple of weeks, but certainly by 2 months, 8 weeks, 10 weeks, that patient really ought to be better with most of the therapies that we would have embarked on. So that's the immediate target. The intermediate targets are really more, not only are you feeling better, but are you feeling well and for all intents and purposes completely normal again, right? So clinical remission is how I define it to patients. Are you feeling completely normal? But we also try to pair that at that intermediate time point. I'll say 6 months in general is a good intermediate time point to pick, whether or not there's been an improvement in some of the inflammatory markers. We, in inflammatory bowel disease and both ulcerative colitis and Crohn's disease, can follow these inflammatory markers like C-reactive protein, which I assume all of you have been doing, and fecal calprotectin, which has become much easier to check, even though patients still hate collecting stool, as all of us know. But those can be really good measures to track how patients are doing at that intermediate time point, because patients don't necessarily want to have colonoscopies done every 5 minutes, even though they're so much fun for us as gastroenterologists. And then there are, of course, the long-term outcomes. Can you have not only the patients feeling fantastic, improvements in the fecal calprotectin, but what about the endoscopy? Has there been mucosal healing? Has there been endoscopic improvement in that patient? And ultimately, what we want is for people to live normal lives. They're not thinking about inflammatory bowel disease, and this is not leading to long-term disability and them being out of work and not having any fun. So, it's called STRIDE 2 because there was a STRIDE 1, and STRIDE 1 was published in 2015. And in 2015, we felt that, the endpoint should be really an improvement in the endoscopy. By STRIDE 2, we sort of felt that we really needed to have that endoscopy really be perfect and beautiful, but we didn't quite feel ready for histology being the main driver of a target, at least in clinical practice yet. And then, our expectation is, of course, that ultimately long-term studies are going to show that having the histology be also perfect will lead to the very best patient outcomes. And these are patients that, for all intents and purposes, are going to have a cancer risk that is the same as anyone with normal sporadic risk of colon cancer, for example. I wanted to show you this example of this study done by Jim Lewis, which I thought was very clever, because I think Jim Lewis is very clever. And in this study, he took patients that had ulcerative colitis. They were feeling fine, clinically fine, but they had an elevated fecal calprotectin. So they were fine, but obviously they weren't perfect, or else their fecal calprotectin ought not to have been elevated. And they asked the question, well, what happens if we take half of them and we leave them alone, and we take the other half and we dial up their mesalamine dose and see if that improves their fecal calprotectin? And the answer is it did, because the patients that didn't have that dialing up of their fecal calprotectin stayed with elevated fecal cals, and those that had higher mesalamine doses had an improvement in their fecal calprotectin. But okay, who cares about that? But in reality, those patients that had a lower fecal calprotectin had a lower risk of relapse. It kind of seems like a duh, but I think it's important, right? You've checked a fecal calprotectin. Don't check something if you're not willing to make a change based on that new result. And in this case, Jim Lewis and his colleagues have shown us that by increasing the mesalamine, in fact, they lowered the risk of relapse in these patients. This is a study from Bill Sanborn and his colleagues at UCSD to, again, ask the question, in real life, could you make modifications in people's medications and lead to endoscopic improvement and histologic improvement? And so in this study, they took patients just in normal clinical practice. Some of them had inflammation. Some of them were left on whatever medications they were on, inflammation unchecked, and some had adjustments in their medication or changes in their medications made. And what these investigators show us is indeed, if we change medications or optimize therapies, we can in fact lead to a much higher rate of mucosal healing with respect to endoscopy and with respect to histology. So it could be done even in the real world. It's not just in a clinical trial. Much to the chagrin of our colorectal surgery colleagues, we're doing something right, and we're reducing colectomy rates in patients with ulcerative colitis. And I would argue this is because improvements in therapy in ulcerative colitis. I'll remind you of the results from the Act 1 and Act 2 studies where we gave patients with ulcerative colitis infliximab or not. And those patients that received infliximab had an improvement, a decrease in colectomy rates by the end of the year. That's very notable. I think you and I know that the Achilles heel of these therapies, like the anti-TNF therapies, is the loss of response over time. And that's kind of why we haven't made even more traction with respect to reducing colectomy rates even further in these patients. How high do we want to set the bar? Do we want to set the bar at Olympic height? Or, as I like to think about it, is it really like a limbo dance and you want to set the bar really low, which is to say you want to really reduce inflammation to the lowest possible levels of inflammation, of course, without having the risk of toxicity in these patients with IBD. So this is an example of what happens when we leave a little bit of inflammation and we allow imperfections, right? We allow there to be some inflammation. And in this study, they separated patients into those that had a little bit of inflammation, like a Mayo 1, friability, a little erythema when you did a colonoscopy, or they really didn't have inflammation on endoscopy, but they were allowed to have a little bit of inflammation on histology, or finally, the Uber group that had no inflammation endoscopically and no inflammation on the histology. You can see that the rates of relapse for those groups are substantially different, right? We accept that a quarter of them are going to have a flare, a relapse within a year if they have a little bit of inflammation on endoscopy, whereas those patients that had no inflammation on the endoscopy and no inflammation on the histology had like a 5% or less rate of having a flare over the course of the year. That's a big difference for patients that complain to us that they feel like they're on a roller coaster and they don't know when to expect the next flare. There has been a lot of discussion about histology with respect to ulcerative colitis, and there are different histology scores that are being used in clinical trials. And this shows you kind of the three main ones that have been used in clinical trials. I don't want to bore you with all the details, but really in reality what we're trying to achieve, and what is true across the board of all these different scoring systems, is what we want to do is have zero to as few neutrophils as possible in the mucosa of these patients with ulcerative colitis. That seems to be the most important determinant about whether a patient is going to have a relapse or not. It's really about the neutrophils. And so to that end, what's happened is that there's been an evolution of what we consider mucosal healing, right? So it's, I'm sure, driving many of you crazy. What's the latest definition of mucosal healing? And over time, these clinical trials in a reasonably short period of time have gone from expecting there to be endoscopic improvement, and all that really started in the era of biologics with endoscopic improvement, to really having endoscopic, like minimal inflammation. In fact, the most recent endoscopic like scores of 1 aren't allowing there to be even friability, right? So if you think about that when you do endoscopy on your patients, these are patients that maybe for many people would look like they're normal, but perhaps they have some mild erythema. And in the most recent studies, and we'll be talking later with Tim about upadacitinib, in fact, they've set the highest bar, which is absolutely no inflammation endoscopically and absolutely no inflammation being seen histologically. And so that dimension of histology is one that you'll see as I talk to you some more in this conversation, that we've now dialed in adding histology as another parameter in which we evaluate patients with ulcerative colitis. That party was started really with ustekinumab and those ustekinumab clinical trials that not only evaluated the endoscopy, but also evaluated the histology, and in fact got in their label that it leads to both histologic and endoscopic improvement, or the HEMI score, in patients with ulcerative colitis. These are the data for ustekinumab, and I wanted to show you these data for a particular reason. What you can see is that at week 8, already treatment with ustekinumab was separating from placebo with respect to both endoscopic and histologic improvements. But what you can also see is that at the end of a year, those numbers are much higher. And all I want to say is, of course, it requires patience. Rome wasn't built in a day, and improvements in both endoscopy and histology are going to take longer than 8 weeks, but obviously in a clinical trial, they're being evaluated very early on. I want to tell you a little bit about upadacitinib in the rest of my conversation with you, and so I wanted to show you some of the endpoints that were used in the upadacitinib studies for ulcerative colitis. And so there were some composite scores. These composite scores always involve clinical symptoms, how the patient is feeling, rectal bleeding, stool frequency, and all of that, combined with some amount of endoscopy. And finally, as I said, we have dialed in this histology piece, and we have decided that we need to have a very low pathology or histology score in order to consider these patients to be in histologic improvement as well. So this is comparing across studies, and obviously I know you're too sophisticated to allow me to compare across studies. On the extreme left, you can see the data for ustekinumab with respect to histologic and mucosal improvement at 8 weeks. And then there were 2 identical studies done of upadacitinib, UPA, compared to placebo in patients with ulcerative colitis, and you can see that, again, very high separation from placebo at week 8 with respect to endoscopy, with endoscopies being nearly normal. Again, remember that was the standard that was set by them, as well as histologic improvement. And these are patients, I should also add, that about half of these patients were biologic experienced, right? They had been on previous biologics, often multiple biologics, and we all know that patients that have been exposed to biologics previously are a more refractory bunch and have sometimes worse outcomes. So really, what's the future hold? And so I love this study design. It's called the Verdict study. It's being done by Alimentive, but really designed by some of our lead thinkers in the world of clinical trials and IBD. And this really kind of is challenging us to say, okay, fine, prove to us that some of these outcomes and some of these endpoints that you've set in clinical trials are really going to be meaningful, and show us that, in fact, if you've set a target, that we can actually increment therapy and achieve that target. And so they're going to randomize patients in real-world settings into one of 3 groups. One is going to be just symptomatic remission with ulcerative colitis and off of steroids. The next will be symptomatic remission off steroids, and the endoscopy has to be better. And then, like the final group is improvements in their clinical symptoms off of steroids, the endoscopy has to be better, and the histology has to be perfect. And so we will compare all these 3 groups, and again, what the idea is that at different time points, they will be evaluated, and those investigators, depending on the group they're in, they're going to modify therapy or optimize therapy to achieve the particular target that has been set for that patient. And at the end of the day, we're going to really look at the real targets. Then the real targets are, they got to keep their colon, they have no dysplasia or colon cancer, and that they feel normal, that they're not thinking about where the next bathroom is, and that their quality of life has normalized. And so I think this is really going to be a phenomenal study that will inform whether some of the endpoints that we've set for these clinical trials are really going to be meaningful at the end of the day. So what does the future hold for our patients with ulcerative colitis? My sincere hope is that we'll be able to do a blood test, a microbiome test, right at the time of diagnosis, and be able to know what the future holds for that particular patient, and how best we're going to manage that particular patient with medications that are targeted to their specific inflammatory pathways. How far are we away from that? I can't tell you, but I think we're getting closer every day, and I hope that the conversation we've had today has really highlighted all the ways in which we've made improvements in the care of patients with ulcerative colitis. So I'm really grateful for your attention. I'd like to now toss it over to Tim Rain, who's at Addenbrooke's Hospital, and is going to talk to us about a case of ulcerative colitis.
So thank you, Maria. Tim Rain here. You join me outside the IBD clinic, and we're going to take a look at the way we can apply STRIDE-2 in clinical practice and what we should really be looking to achieve. So you've heard that beautiful overview of the STRIDE-2 consensus algorithm telling us what sorts of targets and what sorts of timescales we should be looking to achieve for our patients with ulcerative colitis, with the ultimate goal of achieving the best possible healthcare-related quality of life for them. So I want to tell you about a real patient of ours, a patient we've managed in the clinic here for a little while now. When we first met her, we're going to call her Catherine K, by the way. When we first met her, she came to us a fairly typical referral from our colleagues in primary care. She had a history of 9 weeks or so of intermittent abdominal pain. She had loose stools, frequent stools, and those cardinal symptoms of rectal bleeding and an urgency that were really making her life something of a misery. And indeed, she had an excellent primary care workup. We already knew at the point we met her that her fecal calprotectin was well in excess of 600 micrograms per gram, and she had a modestly elevated CRP, just a little bit outside our standard laboratory reference ranges here. We proceeded straight to flexible sigmoidoscopy, and it was very clear already that at least to the limit of insertion, at least to the splenic flexure, she had really quite a good going colitis with clear evidence of mucosal changes consistent with a new diagnosis of ulcerative colitis. So what did we do? Well, she had relatively aggressive disease. This was her first presentation. She needed symptomatic relief, and so she received prednisolone starting at a fairly typical dose of 40 milligrams per day. Now, of course, it's really important to remember that sort of approach is not going to work for everyone. Steroids certainly don't make everyone better, and so she left our clinic already with instructions as to what to do should she deteriorate and a clear point of contact in case of emergency, but also a firm consultation booked with one of our IBD nurses for 2 weeks' time so that she could be reviewed. And really the key question that we want to know at that stage is, are the steroids working? Because if within 2 weeks we're not seeing benefit, already we know that we really need to be looking for alternative ways to induce remission. And of course that's exactly in line with what we've heard already about the sort of short-term, immediate targets that we need to be achieving for our patients. Our patients need and want to feel better, and we should use the drugs we have available to hit that target. But of course, it's always worth asking ourselves whether we could have done anything differently, knowing what we now know. And it's worth reflecting on the fact that, of course, we have a growing weight of evidence for multiple drugs from registration trials showing that we can achieve clear symptomatic improvement and symptomatic benefit as early as week 2 in a typical post-hoc analysis. Indeed, actually, we're now starting to see ever earlier and earlier post-hoc analyses, and Silvio earlier I heard in the studio talking about this idea of targeting not just a single cytokine but targeting a whole pathway, and of course Janus kinase inhibitors do exactly that, and tofacitinib, the pan-Janus kinase inhibitor, showing on post-hoc analysis evidence of benefit for patients as early as day 3. Of course, the Janus kinase family of inhibitors has evolved, and we're now starting to see second-generation JAK inhibitor data with more selective Janus kinase inhibition. And indeed, for filgotinib, we're seeing again evidence of very early benefit measured in days, not weeks, both for patients naive to prior biologic treatment, but also for patients with prior biologic exposure. And more recently still, we've seen data coming out of 2 parallel phase 3 induction studies for ubatacitinib, the UAchieve and UAccomplish studies, again showing very clear, indeed impressive evidence of benefit at early time points for patients with moderate to severe colitis treated with ubatacitinib. Now, you're seeing these data here for the first time. These are going to be shown at the ACG conference in Las Vegas later this month. If you are in Vegas in late October, do drop by in between catching a show. You'll see this presentation, and what we're showing here is that the benefit of ubatacitinib was seen equally in patients with no baseline corticosteroid use, but also in patients who were on baseline corticosteroids. In other words, there wasn't any apparent benefit to patients in this study, in a non-randomized manner, to remaining on corticosteroids, suggesting we may indeed be entering an era of treatment when we can do away with the need for corticosteroids in induction therapy completely. So what happened to Catherine? Well, if we go back to her story, because she had this relatively aggressive disease, because we weren't going to use long-term corticosteroids, she needed a maintenance treatment, there was a sense that mesalazine alone probably wasn't going to cut it, and so she went on to a combination of mesalazine therapy and was loaded with a typical dose of azathioprine. Now, by week 10, she was doing better. It was clear she was off steroids. Her bowels had greatly settled. She was only opening them once or twice a day, but that's still more than what was normal for her. And she was still troubled by occasional bleeding and urgency. And I think it's fair to say that if we remind ourselves of what STRIDE's asking us to achieve for these patients, Catherine hadn't got there. Remember, we're looking to achieve not just improvement, but actual clinical remission, defined here as the absence of rectal bleeding and a normalization of a bowel habit. And indeed, we're looking for biochemical normalization as well. So how could we have got there, or what could we have done differently for Catherine? Well, let's stay with the Janus kinase inhibitors and let's look at the data for tofacitinib and remind ourselves that, again, what we're seeing here is evidence of clinical remission achieved for patients treated with tofacitinib as early as week 8, and indeed this benefit appears relatively constant regardless of whether patients have been never treated with a biologic therapy or never experienced biologic failure, or patients who have previously experienced failure of biologic treatment. And again, we can look at a similar analysis for filgotinib and again see evidence of benefit both for patients naive to biologics and patients with prior biologic experience, again against these tough week 8 clinical remission endpoints. And again, if we now turn our attention to the latest data for upadacitinib, we can remind ourselves first of all very clear evidence of benefit in the whole population in terms of clinical remission from these 2 parallel induction studies. But again, when we break this down by patients who have previously experienced failure of treatment with a biologic and patients who have not had that experience of biologic failure, again we see consistent evidence of benefit for both these groups of patients against this very tough early endpoint. And what that translates to, again, is that there is no apparent difference in the percentage of patients hitting these sorts of endpoints, regardless of whether or not we're looking at a group that are previously treated with corticosteroids at baseline or those who are not on corticosteroids at baseline. So what happened next to Catherine? Well, look, by 6 months into her treatment, she still had some persistent ongoing symptoms. Retrospectively, we could say she wouldn't have met that intermediate goal of STRIDE 2. And so at that point, appropriately, her therapy was escalated, and not untypically, she was given anti-TNF therapy, which was added alongside her existing ulcerative colitis therapy. By 1 year or so into her treatment, she had very clearly achieved both clinical remission, effectively getting on with her life, but she had also achieved biochemical remission. And the question now is really what we should do next. She's living her life normally, she's got a normal fecal calprotectin. Should we be doing anything more? And this is an interesting point of discussion. The first iteration of STRIDE, you'll remember, put a huge emphasis on colonoscopy, and there was some criticism almost that there was too much emphasis on the need for colonoscopy. But actually, if we look at the latest iteration of STRIDE, again, we're still seeing mucosal healing there as a therapeutic long-term target. Why is that? Because, of course, we know that patients who achieve this will have the best long-term healthcare-related quality of life. And so this leads to interesting discussions with the patient. In Catherine's case, she was very clear that her ultimate goal was to achieve the best possible long-term outcomes. And so for that reason, we discussed with her and we agreed to perform a colonoscopy. But of course, there's no point in medicine in doing something if you haven't got an intervention that can help you achieve whatever target you're aiming for. And again, let's remind ourselves that, again, if we think about Janus kinase inhibition, it's very clear that we can hit these long-term goals of mucosal healing. So here, data from the OCTAVE studies of tofacitinib showing that if we consider mucosal healing here defined as a Mayo endoscopic score of 0 or 1, significant benefit for patients treated with tofacitinib compared to patients randomized to placebo. It's important we think about benefits and risks, and of course with the Janus kinase class there has been quite a lot of attention on those risks, and we can see already emerging from the phase 3 studies of tofacitinib a safety signal around reactivation of herpes zoster, particularly in patients treated with higher doses of tofacitinib in the 10 milligrams BD arm. Now, of course, we've also seen more recent data for filgotinib, again showing that we can achieve not just endoscopic remission, but actually go even further and look at really driving the neutrophils out of the lamina propria and achieving histologic remission. Again, clear evidence of benefit in terms of both of these targets for the induction and maintenance studies of filgotinib. And again, broadly quite encouraging and reassuring safety data emerging from the filgotinib safety profile and overall quite reassuring data from the maintenance studies. And if we look now at the data for upadacitinib, starting perhaps with some of the softer endpoints, endoscopic Mayo 0 or 1, akin to the endpoint you saw there in the OCTAVE studies, we can see endoscopic improvement in a really large and significant fraction of patients treated with upadacitinib. We can go further than that. We can ask whether we can improve the histologic appearances of the mucosa, and indeed whether we can even achieve endoscopic remission. And across all of these outcomes, we're seeing clear and significant evidence of benefit for patients treated with upadacitinib. Now, what does all that mean? Well, in patient terms, what this means is that our patients can and do achieve sustained disease-free remission. And that's very clear in these important secondary endpoints of the upadacitinib maintenance studies, with clear evidence of maintained corticosteroid-free remission presented here at UEG for the first time this week. And again, let's remind ourselves of the risks and benefits. And I think what we can conclude at this stage is that there is a favourable risk-benefit signal emerging around upadacitinib with broadly, again, reassuring safety data from the phase 3 studies. Let's go back one last time to Catherine's case and ask what happened next to her. Well, look, you'll be pleased to hear she achieved those targets. She had Mayo endoscopic score of 0. She was in histologic remission. And so for that reason, she has remained on her combination therapy with anti-TNF therapy, thiopurine, and mesalazine. And of course, the question that then always arises is, how do we monitor these patients? How do we follow them up? And should we ever de-escalate therapy? And in Catherine's case, what we've agreed with her is we're not going to push endoscopy too hard. For the time being, we're going to make use of a fecal calprotectin recorded at every other infusion visit. So about once every 16 weeks, we'll have biochemical evidence for Catherine. Obviously, we're going to continue to assess her symptoms, and she'll fill in an e-record every time she attends for an infusion visit, and that will go straight into her patient chart so we can monitor, and there will be alarm bells flagged automatically if her symptoms start to go off. And of course, even for a patient who's achieved biochemical and clinical remission, obviously the continuity of care and contact with the clinical team remains essential, and so she will continue to have follow-up visits in the outpatient department where she can raise her concerns and continue to learn about her disease and talk to us and know that we are there for her if and when the need arises. So look, I'm going to wrap up and hand back to you in the studio in a moment, Maria, but what I really hope I've got across is this idea that the STRIDE-2 consensus now gives us a framework to work off the short, the medium and the long-term goals and targets that we need to be talking about with our patients and really understanding how we can achieve them. But not just doing that, but also revisiting. It's not just enough to go through the STRIDE algorithm once. Clearly, you know, having won this hard-fought long-term remission for Catherine, it's important we continue to monitor that. We know that loss of response is still a problem, particularly for patients in Catherine's case treated with anti-TNF therapy. So we're going to have to keep a watch on what's going on and really make sure we're still where we need to be. And it's also important, I think, to think about ways that we can and may do things differently in the future, perhaps turning to generations of therapies that can achieve not just rapid induction of remission, but long-term maintenance of remission in the simplest and safest way possible. And I hope and believe that Janus kinase inhibitors will very much fill an important gap in the treatment landscape in that regard. So thanks very much. Back to you in the studio, Maria.
Thank you, Tim, for presenting that really informative case. I'd really like to take the opportunity to thank my co-presenters today, Silvio Danese from Milan, Tim Rain from Cambridge, for their really outstanding presentations. I hope all of you will agree that we've come a long way from the days of True Love and Wits, and that's been based on really a better understanding of what causes ulcerative colitis so that we can target therapies. We've also evolved in a really reasonably short period of time from treating single pathways like we would with anti-TNFs to affecting multiple intracellular pathways as we do with the JAK inhibitors. But we've combined that with having more stringent endpoints, setting a higher bar for ourselves and for our patients in the hopes that we'll achieve better outcomes. At the end of the day, we need to prove that these improvements in our therapies will lead to really the most important long-term outcomes for our patients, which is that they don't have a colectomy and they don't develop colon cancer. So thank you for joining us.